Now, first of all, let me ask you, how many of you have done single tooth, immediate tooth replacement in your career? Most of you, all right? So let me ask you, do you face problems like this ever? Anybody? Okay, well, only one person raised their hand. That's great. Okay. So, but the thing is, when you look at immediate tooth replacement, these are some of the problems sometimes we face, such as gingival recession, discoloration, and I want you to look at this new term here called incisal-facial contour changes. That means after the treatment, how that contour collapses. Now, mind you, each one of these three factors tends to go hand in hand with each other. That means if one goes wrong, typically it may cause problem with the others. So we're going to focus on today, what can we do to minimize these problems when we do single tooth replacements immediately? And also we want to take a look at, can we apply this rule to guide the surgery as well? To begin with, we're going to show you these patients that fly from Minnesota to Los Angeles to see me. And obvious problems of failing left central incisor. Husband's a plastic surgeon, okay, and they say money is not the object. I want the best for my wife here. All right, now you can notice on the left-hand side of the screen, you see that little bump there. The issue is every few months that little bump will come up, and you can use your finger to push it. There's some white creamy stuff that come out, and you know that's not that cream of mushroom soup you had for lunch. Okay, so when you look at this situation, you know thin gingiva, high smile line, what can we do if we were doing immediate tooth replacement? Now, I will give you some of the guidelines, what I follow through in my career, in order to create predictability to control that facial gingiva. Now, let's quickly go through each one of them. First of all, thickness, something that we must identify, gingival biotype. Now, the way I identify the thickness of the gingiva is very simple. I utilize that periodontal probe, first probe the sulcus, then gently lift the probe towards me facially. And if I can see the very outline of that probe shining through, what that tells us is towards the thinner side. Now, we all know thin gingiva from dentistry standpoint is kind of like a loser. Why? Because upon surgical and or restorative insult, there will be a high chance of gingival recession. The next factor we want to look at is the bone. Why? Underneath the facial aspect of every tooth, if I refract the gingiva, I will expect to see a layer of bone. The question is, how far should that bone be underneath that gingiva? Well, to answer the questions, I'm going to use two pieces of scientific evidence so you can understand how it works. The first article was published over 50 years ago by three persons, Gargillo, Wentz, and Orban. Remember Orban knife? So that's Dr. Orban there. What they did is on dead human beings, they took out the jaw, and then they did histology, looking at the area between the free gingival margin to the underlying bone. Now, the key point that you want to remember at this point about this publication is this. From gingival margin to the bone, it makes up of these three histological components that you will worse off. Sulcus, junctional epithelium, and the connective tissue attachments. The second point that you want to remember is this. Each one of these components possess a certain dimension. In other words, for a patient who is periodontally healthy, and if the tooth had been erupted in a normal sequence, each one of these on an average have a dimension of 1 millimeters. Therefore, the total distance between gingiva to the bone, people often refer to is that 3 millimeters. Now, this is a histological study. How can we apply this clinically? Well, my friend John Coyce published this article, tried to address that. What he did is, on a group of patients, maxillary central incisors, he first anesthetized the patient, and he took a periodontal probe and did bone sounding on the mid-facial aspect of those patients' teeth. By doing so, he was able to categorize his patients, the distance between gingiva to the bone, into 3 groups. The normal, high, and the low crest group. Now, normal has the same distance that what Gargillo talked about, that's magical 3 millimeters. Then, of course, high is less than 3, and low is greater than 3. The key point we must understand is this. Nowadays, in periodontology, in terms of tissue management, there are 2 things one must know. First of all, in order to have soft tissue, we must first have bone underneath there to support it. Furthermore, we also now understand there's actually a cohesive relationship between gingiva to the underlying bone. That relationship on the facial aspect of the tooth tends to be 3 millimeters. In other words, once the distance between gingiva to the bone exceeded beyond 3 millimeters, such as in a low-class environment, upon surgical and or resorptive insult, the risk of gingival resection is high. So, bone normal is 3 millimeters below facial gingiva. Now, let's go look at our patient from Minnesota. Anesthetized patient did bone sounding. It's within 3 millimeters. Now, this is one of the criteria that clinicians usually follow if they want to do predictable facial gingival aesthetics on immediate tooth placement. Now, let's take our thinking process one step further. What happens if, first of all, we know the bone is 3 millimeters below the facial gingiva. What happens if you as a surgeon put the platform, as indicated by the right arrow of those implants, put it deep into the bone? The question is, can bone be sustained above the platform of the implant? Now, this is to be published prospective study. What the office is prospectively evaluated 6 implants. And essentially, they're all placed in the aesthetic zone immediately. Right after the surgery, the office take an standardized radiograph looking at the bone mesial-distally. Now, you can essentially draw a line right here, separating the 5 implants on the right and 1 implant on the left. Now, what's the difference? The 5 implants on the right possesses what you call platform shifting concept. Now, will that hold the bone better? Let's take a look at the bone loss at 1 year. Interestingly enough, you can see a significant difference, though clinically not that great of a difference between the platform shifting group and the non-shifting group. Now the question is, can bone be sustained above the platform of the implant if the implants are placed deep? Let's take a look at the numbers right here. What it is essentially is this. Implants are placed, take a radiograph, looking at right after surgeries, how many of the proximal sites are positioned, the bone, the position at or coronal to the platform of the implant. 1 year later, take that x-ray again to see how many of those sites still remain, the bone still remain above the platform of the implant. Well, interestingly enough, once again, you see the superiority of the platform shifting group. However, if you look at the percentage-wise, you do not see 100%. Point is this, ladies and gentlemen, if you put an implant too deep, it is pushing against the biology. I always like to tell my residents, when you put an implant too deep, it's almost kind of like an intentional crown lengthening procedure. All right, so to answer the question, can bones be sustained above the platform of the implant? Most of the time, no. But with the newer design, maybe. All right, let's go back to our patient from Minnesota here. You notice there's an infection there. Question, would you put an implant immediately in an infected site? What do you think? Well, I once remember someone told me, if you're not, treat the patient as if that patient is your mother-in-law. If you're not going to do that to your mother-in-law, please do not do that. All right? So you will not put an implant immediately in the infected site. How do you maintain, how do you deal with situations like that then? You want to maintain the gingival architecture, right? Well, what I do is I do a little tunneling procedure, try to drain out the infection. See whether I can control that infection. If I can, then we can still utilize this situation for immediate implants situation. So around 3 months later, you can see infection subside, and we decide to do immediate implant placement. Let's spend a minute talk about implant positioning when you do immediate implant. Now, we all know when we look at immediate implant placement, the key to the success is implant stability. One may wonder, how do we attain stability? In my opinion, there are 3 things one must consider. The first 2 have to do with where in the bony socket you as a surgeon are supposed to engage the implant into the socket. The last thing is you need to ask yourself, does the shape of the implant affect stability of that implant? Well, let's look at the anatomy first. First rule is this, implant should be engaged at least good 4 to 5 millimeters apical to the root tip socket, such as this case here. Now, then we look at this sagitally. I use Photoshop to outline the sagittal outline of the root there. The key is, you as a surgeon, you want to engage the bone palatal to that socket. So these are the 2 areas that you want to engage that implant to get stability. Now, unfortunately, the root does not always position in the socket like this. This article tried to address that. What they did is they look at 600 patients using CBCT to analyze those maxillary anterior teeth. Now, by doing so, they were able to categorize the way the sagittal root is positioned into the premaxillar housing into 4 groups. Class 1, the root is tilting buccally. Class 2, the root is sitting right in the middle of the spony socket. Class 3, you can see the root is tilting palatally. Now that's class 4. in which the buccolingual dimension of the root is greater than the buccolingual dimension of the bony housing. Now, ladies and gentlemen, question. Which one of these four classes do you think is best for immediate implant placement? How many say it's one? Let me see your hand. Okay, 2, 3. Okay, I hope nobody say 4, right? So, in my opinion, the best one is actually class 1, then there's class 3 here. Now, interesting thing is this, when we look at this article, also try to address what is the frequency of distribution of these 4 classes in these 600 patients. Interestingly enough, this is what the data show. Majority of the patient population actually possesses that favorable for immediate implant placement class 1 situation. However, we have a little problem here, ladies and gentlemen. Why? If you notice class 1, if you look at it from a prosthetic retention standpoint, what type of prosthetic retention mechanism can we utilize if we put implants in a class 1 situation? Cement retain, right? And you know nowadays, a lot of people talk about, we're so scared about the cement being retained there, there's problems, And besides that, if you can do a screw retain restoration, especially in the aesthetic zone, you can actually control the subvergence contour a little bit better than using an abutment there. So, but when you look at it, you realize this may not happen very often. All right, now, let's take a look at this study, try to address that. What the authors try to do is this. They look at 1,200 sample size of teeth in the premaxilla. And what they did is they used a Nobel clinician to try to look at how often can we do screw retain when we do immediate implant placement in the aesthetic zone. Interestingly enough, this is the data. Again, 1,200 sample size, all these teeth without any periodontal nor pathology. What do you see here is this? Oops. Less than 20% of the situation, you can put an implant in the aesthetic zone when you do immediate implant placement for screw retain. Not that often. Now, how about in heel size? Well, heel size, unless you graft a lot on the facial, is not that easy too. All right. So, what do we do? What are the if you want to do screw retain, is there any solution? Well, interestingly enough, actually, this company in Nobel came up with this concept here called the ASC, and I found it very intriguing. What happens is they can compensate up to 25 degrees of the angulations to convert a non-screw retain scenario into a screw retain. All right, so how can we make this thing into application? Well, let me introduce this patient of mine to you. Very interesting. She does modeling every time she show up to my office. Her father is like 6'8", 280 pounds, show up with her. And he told me, okay, my daughter, aesthetic is the primary concern. I do not want you to do surgery with raising a flap. I expect her to have a tooth right after surgery, and I expect her to have no swelling. Oh, great, okay. So you know what? I just say, all right, on something like that, I'm going to just, usually I really depend on my hand. This time, I'm going to ask for some software intervention. So I decided to go do guided surgery, all right? But there are problems with guided surgeries too. Well, first of all, I know if I'm going to put a provisional in there will be a screw access hole. And the screw access hole on this situation will be on the facial. Now, what are the other concerns whenever we do guided surgeries? Well, some of the concerns, retention mechanism. Like I told you, the best way is to do screw retain, so we can control the soft tissue. Now, another issue is with guided surgeries, the rotation is hard to index that rotation. So, a lot of clinicians, if they want to put a provisional immediately after surgery, they want to go the non-hex route, the non-index, non-hex route. Now, as you know, it can come loose. So what do we do then? Well, basically for this, as I say, I use a Nobel clinician in this here, do the fusion technique and then retrofit the guide into the cast there. Now, to minimize that, to encounter or solve that rotational issues, I created a silicone jig. The silicone jig is for two purposes. It is to index the depth of the implant as well as the rotational, provide the rotational indexes for the prosthesis there. Then now, how about the prosthetic retention? Well, I utilize this ASC. It's like magic here. I plan it so that it's less than 25 degree angulation and then I make my provisionals. So what happens? I scan the cast, and then I make my provisionals using the ASCs to compensate, to create a non-screw retain into a screw retain scenario here. So now go to surgery, as you know, put the implants in, and you want to be a little bit under drill, and then place it so that you can, with the silicone jig, you can verify your index, but the most important is that percent rotation. You notice that this is right at surgery. When I put on the jig, you notice that it's off. So what I decided to do is to turn it and to get it into a position like that, so that I can just put my provisional in there that's prefabricated at surgery. And so this right after surgery, and this is a 12-week follow-up with the same patient with the provisionals. So, luckily I was able to satisfy this patient's desire. All right, let's talk about implant morphology, how it affects stability here. This article has been submitted to the International Journal of Maxillofacial Implants. What the authors did is they analyzed the 6 implants, and essentially you can draw a line right here separating the 3 on the right and the 3 on the left. Now what's the difference? The 3 on the left is tapered, the 3 on the right is more like parallel shape with various degree of apical shape there. Now, which one do you think can provide better initial stability when you put the implant in? Well, taper or non-taper? Well, let's take a look here. This is the data. You notice that the taper group, none of them have any spinning issues here. However, the non-taper group, especially the 4th one on the list, quite a bit of spinning issues. Now, I'm not here to tell you whether they're good implants or not. Okay, they are actually very, very decent systems here. But the thing is, when you have a spinning situation, in the immediate provisionalized situation, it becomes quite a bit challenging. Now, what are the factors one may wonder that can affect implant stability? Well, besides implant morphology, we talk about how about the bone quality and quantity? How about the surgeon's experience? Now, I leave the last area blank here because it took me a little time to figure this out. But when I thought it out, thought through it, when we submitted for publication, I found this very interesting. I like to call that FDIDD. What FDIDD means is the final drill implant diameter discrepancy. In a sense, when we look at the final size of the implant and the final drill, we merge them together. Typically, or hopefully, the final drill should be smaller than the final implant diameter, right? Now, surprisingly enough, every implant company, the discrepancy differs. Let's take a look at what we find out here. As you notice, when I put the list here, you can see the instability percentage increases as you go down the list here. But when you look at the FDIDD, interestingly enough, it is actually inversely proportional. The group that has the smallest FDIDD has the highest chance of potentially spinning issues. So it's something that you as a surgeon or clinicians should put that into your considerations too. All right, when we talk about implant position, buccolingually, this is a classical position. You want to leave a gap between the implant and the buccal bone of around 1.5 millimeters. Now, how do we achieve that? And what can we do to minimize facial gingival recession? Well, first of all, let's start by looking at the implant diameter. Well, why? Because implant diameter is going to affect aesthetics. What are the factors that govern implant diameter? 2 things. First of all, the size of the gap, and then the size of the socket. All right. First of all, let's talk about the size of the gap. What size gap should we leave in there? But maybe before I even go there, we should back up a little bit and ask ourselves this question. If we have a gap, we know no matter what, when we do immediate implant placement, inevitably there will be a gap. The question is, should we or should we not graft the gap? Well, what I'm going to do is show you this to be published material here. What the authors did is this. They look at patients that were treated with immediate tooth replacement with 3 different time frames. Now, why 3 different time frames? Because as a clinician, I'm just like most of you, the type of treatment I bestow on the patient, or the philosophy is when I attend a lecture, I listen to somebody, someone say, Joe, you should do that. And I say, all right, superstar, so Dr. so-and-so say that, I better go home and do that, right? And so, over the years, I evolved and I changed. And I believe this 3 time frame, it basically covers all the different methodologies that you as a surgeon, how you should manage the gap. Let's take a look here. Very early on, I follow the rule. If the gap is 1.5 or less, do not graft. You heard about that, right? So most of the cases, early on in my career, no grafting. Then later on, when I looked at on group 1, I realized we have some problems. So we better do some grafting. So the second group, we always graft inside the gap. Now, more recently, we changed one more time because when we observe group 2, sometimes we run into problems too. So now what we do is this: not only when we have a great gap, we graft inside. We also graft outside the gap too. All right. So how would that affect each one of those? So what we did is this: we retrospectively collected. We have all the casts and all the photos of those patients, and then we retrospectively recall them. So group 1 has the longest follow-up. Let's take a look at what can we learn from them. We look at the incisal-facial contour changes. This patient as an example, what do you see? Well, you can see that the facial tissue collapses. Now, why did it collapse? Well, if you believe in people like Jan Lindy's publications, right? Every time, when you extract the tooth, the bundle bone is gone, and there goes the buccal plate. So no matter what you do, the buccal bone is going to be compromised. And now, if you do not put any bone graft in there, and if that patient happens to have insufficient blood supply to the socket, so you don't have a nice blood clot, guess what happened? You will see a significant buccal plate collapse. And based on this data here, over 100 patients, almost 70% of the cases display this type of problems. Now, how about when you graft inside? Okay, we'll notice that a lot of cases we have partial collapses. And partial collapses created discolorations to those patients frequently. And we noticed 30% of the cases display this type of characteristics. Now, how about if you were to graft inside and outside? Unfortunately, this group has the shortest follow-up, but still long enough to give us an idea. Not every case is perfect, because just remember, the buccal bone tends to remodel, and the bone graft you put inside the gap never means 1 + 1 = 2. You know what I mean. When you put a piece of bone in there, 1 + 1, 8 months later, I pray really hard. If I get lucky, I will get 1.6. On a bad day, 1 + 1, I sometimes end up getting 0.7, and it's terrible. All right, so the point is this. Now, I told you the 3 factors, they all interrelated: recession, discoloration, and facial contour changes. When you look at all these patients with facial contour changes, how about gingival recession? Very interesting. When you look at the numbers here, you'll see that there's not that big of a difference there. But the difference is the range, ladies and gentlemen. When you don't graft, that range tends to be, differs significantly. So in my humble opinion, I think the key point is in 2014, when we do immediate tooth replacement, consider overgrafting to compensate for that buccal contour changes there. Now, how about discoloration? Well, this is what we notice. Again, the group without any graft in the socket have a high tendency of the implant, showing through. All right, so let's focus a little bit more about that buccal contour, because that seems to hold the key to the success for most implant aesthetic reconstruction, right? Well, this patient, I want to show you, same patient here, I did immediate implant placement, leave a gap there, put bone graft in the gap. Now, 9 months later, mind you, this patient doesn't need to raise a flap. Actually, 9 months later, when the patient comes in for final impression, I gently ask him, do you mind if I kind of numb you and open up the gums and take a look? And he kindly said yes, okay? I always, besides thanking my mentors like Charlie Goodacre, me standing here, I need to thank a lot to my patients too. Sometimes my patients really went through a lot, for me to be able to stand up here. Now, what did we learn here? The question is, when we graft inside the socket, can we maintain the buccal contour? What do you think? Not really, right? So when we do ridge preservation, does it essentially preserve the ridge buccal lingually? Well, not 100%, right? Well, you can see this is a situation here. So remember, but the question is, we are here today to ask ourselves, what size of gap should we leave buccally when we do immediate implant placement? Well, let me tell you, in my opinion, the size of the gap that we want to bestow on our patients when we put implant in the aesthetic zone is to compensate for facial ridge remodeling. What I'm trying to tell you is this. We know that facial ridge remodeling is inevitable. no matter what you do, whether you put bone graft in there or not, or sometimes we're hoping that that buccal plate is really thick. So because of that inevitable remodeling, if we put an implant and the gap is too small, in other words, the implant will be a little bit buccal like this, guess what happens? After the ridge is remodeled, now there may be hardly any bone on the facial aspect of that implant, and it will create an aesthetic problem. That's why we want to leave a gap that is big enough to compensate for that remodeling there. Now, in order to appreciate what size gap, then one must understand how much does the ridge remodel when we extract a tooth. Well, let's look at some of the classical publications that address this issue here. You see the last two have a green asterisk in there. That means they are the groups that you either have an implant, you have an implant in the socket. What the group did is you either, after extraction, you measure the horizontal ridge width, you either put bone graft or no bone graft in there, either with or without an implant. Now, what can we learn from this data? Very straightforward. What do you think? Is it better, ladies and gentlemen, to graft or not to graft? What do you think? Graft or not graft? Graft, right? Always put something in there. It's better to graft. But when you look at it here, you look at something very interesting. Despite grafting, this is a key point. First of all, we know it's always better to graft. But the problem is, even with grafting into the socket with or without implants, you will still expect it doesn't completely preserve the ridge. You can still expect a certain degree of remodeling. Now the question is, how much remodel, where does majority of the remodeling occur? What do you think? Buccally or palatally? Buccally, right? Because of that thin and vulnerable buccal bone, right? And which area affects aesthetics the most? Buccal, right? So in order to understand what size gap we should leave for the patient, maybe we should focus right here. The question is, when we do implant or when we do extraction, how much buccal bone collapses can we expect? Now, these publications in 2012 try to address that. What the authors did is this. Immediate implant placement utilizing CBCT scan. Right after the surgery and of immediate implant placement and put bone graft into the buccal gap, take a scan. Then 1 year later, take the same scan. Now, they utilizes this software called Osiris and able to do what you call standardization of the CBCT data. Now, what do we see here? Let's see. And what they did is they measured the buccal bone changes all along the buccal wall there. This is the mean data here. What can we learn to appreciate that? Well, what we notice is that no matter what we do, even putting bone graft into the gap, buccal bone will collapse in. Now, if you look at this area, which area do you think along the bony ridge does majority of the resorption occur? The crestal region. Interesting. Now, which area tends to affect aesthetics the most? The crestal region. Which area, when you do guided bone regeneration, is you have the most challenging time? Usually the crestal region. Sometimes I almost need to look up in the sky and say, why? It's so humbling. All right? So, what can we do here? Well, the thing is this. We know if you take away the crestal regions, the remaining buccal bony wall, there's less than around half a millimeter of bone remodel. So, just to prove a point, is what Dr. Lindy, what he said, is it true? That means that bundle bone issue, and when you extract the tooth, that buccal plate is going to remodel. Well, when we ask ourselves, what is the average buccal bone thickness? This article tries to address that. What they look at is this. They first of all do CBCT scan on premaxillary teeth, and they utilize a method that they learned from a group of periodontists from Brazil, in which when they do the scan, they retracted the upper lip utilizing orthodontic retractor. Now, by doing so, what did that group of periodontists in Brazil show us is by doing so, you are able to see the buccal bone and the facial soft tissue a lot clearer. By doing so, interestingly enough, or expected, the buccal plate is thin on an average less than 1 millimeter. So let's put what we've learned and put it into action here. We know that the average thickness of the buccal bone is 1 millimeter, right? Then we also know, even by putting bone graft into the socket, the buccal bone will remodel, especially in the crestal region, up to around 1.2, 1.5 millimeters. But our question is, we want to leave a gap how big that gap is. Now, remember, the gap is to compensate for that facial bone remodeling. So what size gap should we have? After the remodeling, we should at least still have 1 millimeters or greater of bone buccal to the implant. If you do the calculation, the answer is very simple. You need at least 1.5. Anything less than that, potential problems. Potential to say hello to that implant one day down the road. All right, so this is what we say, 1.5. Now, how about socket size? And how will the socket size affect implant diameter? Well, let's take a look at this patient here. I just extracted the patient's left central incisor. And I intentionally put a periodontal probe there to measure the mesial-distal dimension of that tooth. Question, with this dimension, what size implants would you select for your patient? Well, most people, this is the rule they follow. They follow Esposito's classical publications, in which what they say is this: to minimize proximal bone loss, you need to leave at least 1.8 to 2 millimeters of bone between the implant and the adjacent root. You've heard of that, right? So if you do the calculations, 9 minus 2 and 2, well, you get around 5 millimeters. Now, before you start putting a 5 millimeter implant into this patient, I want you to look at this patient from a different point of view. From the incisal point of view. And again, I put that periodontal probe in there. And what does it show you? 7 millimeters. Now, question, would you still now put that 5 millimeter implant in this equation here? No, absolutely not. Why? You know you need at least 1.5 millimeter of bone buccal to that implant. And you know you also need at least 1 millimeter implant parallel to that implant. And if you do the calculations, suddenly you realize any implant that's 4.3 will be too big in the equation. So what's the key point to bring home? Key point is this: buccal-lingual really dimension dictates implant diameter. Now, does that mean we never use mesial-distal dimension? Not really. There's only one scenario we utilize the mesial-distal dimension. That is only if it is smaller of the two. Now, why is this concept important? Because Edge publications, long time ago, when they look at the average dimension of the root, of maxillary anterior root at the cervical regions, using caliper measurements, these are the numbers. What is the point then? Well, in order to put a 5 millimeter implant into the socket, not the ridge, the root at the emergence profile need to be almost 8 millimeters or greater. And we do not get that very often. So key point is this: next time when you go back to your practice, if you plan to put an implant that is 5 millimeters or 6 millimeters or 7 millimeters in the patient's anterior socket, please stop and ponder and think 10 times. Is it needed? Now, because if not, once the bone remodel, the implant may end up showing through. All right, so let's draw a summary. We know the buccal bone on an average 1 millimeter, right? And we know the remodeling can occur up to 1.5 millimeters. Now, because that and we talk about that 1.5 millimeter gap, and because most of the buccal-lingual dimension of the socket for teeth in the aesthetic zone is 7 millimeters or less, therefore, implant diameter should be, on an average, 4.3 or less. All right, so that's the equation. So what did we learn here? It's good that we know this is how the formula is supposed to be. But by doing so, it still does not prevent that buccal contour changes, that inherent buccal contour changes. So what can we do? Well, under such circumstances, maybe we should consider about grafting outside to compensate for that inherent bone loss. Now, how do we do that? Well, I will take you back to our patient from Minnesota here. High smile line, thin gingival type, very high value gingiva. Those are the type of cases that when you make incision, or just maybe I should ask you that, if we make an incision like this after implant placement to put some bone graft out there, how do you think the gingiva will begin to look like? Well, people say scarring. Let me tell you, don't worry about scarring. Majority of the time, it is an overstatement. Why? Because to have scarring, you need to have one component called collagen. When we look at histological study, what do we see? When we look at gingiva-wise, when we compare the attached gingiva between free gingival margin to mucous gingival junction or the mucosal tissue,
do a full thickness dissection, lift the periosteum off, and here specifically I utilize a resorbable membrane. Where we try a lot of cases without resorbable membrane, it works equally well, as long as your periosteum is intact there. Then graft underneath there. So this is how the system works here. Basically, bone normally is what, 3 millimeters below the gingiva. Remember, we ascertained that by bone sounding. Then, I like to put a little tissue graft right here at the crestal region. Now, why the tissue graft? Remember I told you early on, the crestal region tends to remodel the most. And the crestal region is the most difficult area to do what you call guided bone regeneration. Therefore, in my opinion, you can kind of thicken up the biotype right there, utilizing the soft tissue graft there. So I take a little piece of sashimi, kind of like a shrimp sashimi here, if you like that, and put it around from proximal to thicken up the papillae and the facial tissue. Then we put bone graft underneath that tunnel, use the finger, first of all, overgraft it, use the finger to mold it almost into the shape of the root there. The key point is to overgraft, as you can see right here, because the bone graft will remodel. And of course, to protect the gingival architecture, as all the great teachers, like Peter Worley and others have shown before us, that it will help to maintain the gingival architecture. So this is 8 days after surgery. You can see the chromic gut there and the over contouring. This is at 10 months with the provisional. And you can see it's screw retained, and you can see a little mark there using composite to fill the screw retained situation. Now, if you're picky about it, if you look at the color, actually there's a little color differences on the gingiva there. But the thing is, that unfortunate, that is the limitations of human beings. All right. Now, in the future, we may be able to do better, but I think in 2014, this is what we can achieve. Typically just open tray impressions, and if the gingival architecture already been developed with a provisional, the key is to capture that for the laboratory technician to be able to duplicate that. And the best way to do it is to utilize, to duplicate with something that is solid, not just like polyvinyl siloxane, such as in this situation, using composite resin there. You can see on the right picture there, you can see some blanching of the soft tissue. Interesting, right? What it's telling you is this: just a short time it takes for me from removing the provisional to developing the gingival profile with this composite here. The gingiva is already starting to slowly shrink back. That development nowadays, we like to under contour, but under contouring is kind of like a double-edged sword. Some people suggested that it's great for, thickening of the soft tissue there. People such as Eric Rumpen and Bernard Tuorte. But the thing is, it's a double-edged sword. Why? It's very difficult for people to clean the cement. That's why, when we look at situations like that, now I will definitely go with the ASC solution, the angulated screw channel solution, and that will solve that problem there. So place of the definitive restoration, and this is 1 year now. I want you to try to appreciate that buccal contour. It's never perfect, but the thing is, you can imagine the power of overcompensating for that inherent buccal contour changes. And so 1 year follow-up now. I want you to pay attention to the left slide there. The question is, where do I make that incision? Well, you can see the scar band right there. Well, why? Because there's a lot of collagen there. That's why you see that white band there. And typically before surgery, I ask the patient, smile as hard, as big as you can. This is where I start my initial incision. So this is a 2.5 year follow-up. And again, I guess you can appreciate the contour. And then 3 year follow-up here, right? So, ladies and gentlemen, I mean, I think that the journey for immediate implant placement, I've seen it all. I remember when Peter Worley first did that publication, everybody's so amazed. Back in 1998, if I remember correctly, in the PPAD, I think November, December issue. Then I also remember around 2001, 2002, at the Euro-Peru meeting, people condemned this type of procedure. They said, if you do it, be prepared to have a lot of problems. And we witness this.
But just like any other procedures in dentistry, there's a learning curve. And then we also need to substantiate by evidence base. And I'm grateful for people like Charlie Goodacre in our school to allow us to develop the different concepts. And now when we look at worldwide wise, we are seeing very positive results. Why? Because we know how to handle the bone. We know how the biology works. And last but not least, at the end of the day, to create aesthetic results, there's no miracle. It's not because you're using that special bone graft material or even that special instrument you're using here. In the end of the day, it is a biology, ladies and gentlemen. The key to our success as clinicians, in my humble opinion, is really our ability to diagnose and treatment plan and then to execute it. By doing so, in my opinion, we can get there. Thank you once again, Nobel Biocare, Tom, everybody. Thank you.